All right, guys, so today I'm going to be talking to you about psychopathology. But before that, I wanted to go over just some details of the course as we're getting to, kind of the end of the semester. This is our last lab with like a lecture and stuff. After this, we just have our final presentation. So I kind of wanted to talk about what that would look like and what type of deadlines we were going to have, just so we're all on the same page about what my expectations are. So if we take a look at the calendar, I just want to talk about what we're looking at as far as deadlines. So this is for April, so today is the 5th, that's when I'm recording this. And so tomorrow at 11:59 is when your personality lab journal is going to be due. And then I'm going to post all this stuff tomorrow, so you'll have access to it. But this is not actually going to be due until April 20th is when this lab journal is going to be due, along with your discussion, like presentation points, and then what I'm going to count as your attendance points. So watching this lecture, that's not going to be due until the 20th because this weekend is technically Easter, and if we'd been in class, I don't think we have school on maybe, is it this Thursday, Friday, but we have it on a Monday. I don't really know. We're supposed to have a break on this week, I think. So I'm going to give you guys a break. So this, as I said, will be the last week that I post actual material, and it won't be due until the 20th. My advice, though, is to try to get this done sooner because all of your final presentation stuff is going to start being due here on the 24th. So today is the 5th. You guys are going to have until March 24th to do your final presentation. Now, I did ask that you guys submit your topic. That was supposed to be due on the 3rd. If you didn't get that turned in, don't worry about it. You won't get full credit, but if you do submit it at any point after this, I'll give you half credit because I want to make sure you guys are doing a reasonable topic for your presentation, and I'm happy to review anything you guys have. So that leaves you guys 3 weeks before your final presentation is going to be due. So I'm going to go to that module over here and we're going to talk through what the final presentation is going to look like. So here, as I have said, I have a little reminder. This is going to be due for you guys on Friday, March 24th at 11:59. And I'm also going to expect you guys to submit a reference list. So you'll see I've added some stuff here. This is going to be the rubric, which we have had up here for a while. This is the ideas worksheet. This was an activity we did a while ago. Many of you guys have already done this. Don't worry about this one. But here we can see the final presentation reference list. And so this is just going to be like kind of a formatted sheet so you guys can put what your references are for your presentation. If you'll recall, I'm asking you guys to have at least 3 journal articles as reference for your presentation. And I just want to see what those citations are. So if you can submit those APA citations here. And then here I made you guys a checklist. So we're going to walk through this checklist and what my expectations are. And then I'm going to show you guys how to do the submission of all these different things. Okay. Let me see if I can preview it. Sorry, I'm not the most capable person here. All right, so here's your checklist, right? So again, submit that final presentation topic. That was due on the 3rd. Please submit it. If you haven't, I'll give you half credit. Next, I'm going to ask you guys to submit a recording of your final presentation. And that, as I said, is due on the 24th. And there are a couple different ways you could do this. It should be a PowerPoint. You should have a voiceover of you giving your presentation. I know it's a little weird to talk to your computer screen, but that's what I'm asking you to do. To be 8 to 10 minutes long, and just meet those requirements on that guideline document that you saw there on TCU Online a second ago. And there's a couple different ways you can submit this. So here over on TCU Online, if we look under this assignments drop down, you'll see that there are a couple different options here as far as ways you can submit this. There's the file version, and then there's this YouTube link version. I've made these separate because TCU Online won't let me collapse them into one assignment. But basically, you might find that it's going to be easier for you to submit a PowerPoint where you've like recorded your voice over the slides. I do believe this is an option. I have not done it myself. I'm sure you could look it up on the internet. Then I think you can just submit like your PowerPoint as the file. Alternatively, you can do what I'm doing now, which is walking through kind of like a screen recording using Zoom, and then I choose to record that, and then I submit that recording. But that can make a pretty big file, and TCU Online isn't great at handling that. So if you run into this situation where you're like, whoa, I recorded it, but now it's over whatever the 1 gigabyte cap for TCU Online, then you might have to submit this to like YouTube first and then put a link. So I've tried to make all these different options for you available to submit this. If at any time you're like, this is just not working, you can just send me a link or shoot me an email, or maybe you can make a box folder. Just let me know if you're having trouble with this, because it can be complicated, especially if you're now working with like video files. Just let me know. And then you're also at that time, why does it say May 1st? This is going to be the 24th, but whatever. This is just that reference list I was talking about. You need to have at least those 3 APA citations. I highly recommend more than that, but you are only required to have 3. Then if you'll recall, we have this question and answer portion, and to that, I put you guys in pairs, and you're gonna have to watch your partner's presentation. This is by the following Monday, so you have a whole other week to do this. You have to watch your partner's presentation, which I'll personally email to you, or I'll give you the link, or I'll make a way to get that to you. You have to watch that, and then you need to submit 2 questions into this discussion board, which many of you have seen on TCU Online. And then you have to reply to your partner's 2 questions because they'll watch your video. And all of this is still up in an announcement. So if you guys have any questions about how this Q&A portion needs to work, please reference that first. My hope is that it's not super complicated, but as long as you check all of these boxes, at least you won't be missing anything as far as how I'm gonna grade this, and then it'll just be content and your actual presentation. So feel free to use this checklist to help you go through this assignment. Again, I did mess up one of these deadlines. This is actually April 24th. I'll go through and change that for you guys to see it. But for the contents of this video, it'll be a little bit wrong. Okay, so I'm gonna close that. We talked about how to submit that. Again, here's that reference list submission. You can just submit that as a Word document. If your formatting gets a little bit weird, don't worry about it, but just try to follow what APA would suggest. Okay, so now that we've kind of walked through that and the deadlines for that, right, this is gonna do on the 24th. The Q&A portion will be due a week later than that on May 1st. That's all you have to do for this. Let me know if you have questions. I'm happy to smooth anything out if this doesn't make sense. But with further ado, we're gonna go on to psychopathology. Whoa. All right, so today, as I said, we're gonna be talking about psychopathology, which is kind of this idea of diagnosis and treatment of different psychiatric disorders. So first we're gonna walk through what is a mental disorder, and it kind of is a lot of things. It can be things like just mental dysfunction, if you have a lot of personal distress, if your behavior just deviates from the norm, and this norm is determined by things like gender and cultural differences, things like that. There can also be biological like differences, and sometimes even how other people perceive you. So some people might have a mental disorder, but they don't perceive that they are any different than other people. But this is all subjective, right? So if this is different for others, that could also be a diagnosis. And this is often done, this diagnosis portion, by what's called the DSM-5, which is just this big manual that helps psychiatrists help to identify what things might be mental disorders and what things are just individual differences. All right. So there's a couple different defining characteristics, and we're going to walk through a bunch of disorders here. I am by no means an expert on any of these things, and so if you have questions, feel free to let me know. This tends to be a pretty interesting topic, but like I said, I'm not an expert, and so if you see something and you're like, Addie, that's not, I know more about this, then I'm happy to learn about that. All right, so it's typically characterized by this disturbance of cognition, emotion, regulation, or behavior. And so this is clearly a very broad topic. This is not really helping narrow down what we mean. But it also, it's a disturbance, but it has to be clinically significant distress or disability. And so this means that just because you have some disturbance in your emotion or behavior, if it's not this clinically significant level, you're not likely to get an actual diagnosis. And this needs to reflect some type of associative, developmental, psychological, or biological functioning, right? So just because there's a disturbance, but as long as if it doesn't relate back to your biology or psychology or development, then it doesn't get to fall into this category. Additionally, it has to be, like I just said, right, it has to be more than just an acceptable response or common stressor, right? It's got to be kind of like clinically more than that. And it also can't just result as like conflicts with society or just being kind of socially deviant. It's got to be genuinely like a disorder, which I know is like me using terms to define terms, but there's a lot of aspects of this that have to kind of go into a diagnosis. It can't just be kind of like a one-off experience. So there's a lot of different disorders. As I said, this is done using the DSM-5, and this has got a lot of strengths and a lot of weaknesses. So that's what it is. It does this by kind of like organizing different criteria, and it makes several different types. So there are neurodevelopmental disorders. This might be like intelligence disorders or intellectual disorders, obsessive compulsive disorders, which I think this used to fall into anxiety, but it's actually its own thing now. Obsessive compulsive, anxiety disorders, eating and eating disorders, personality disorders, and then ASD, so autism spectrum disorders. And so, as I said, it's got some good things and some not good things. So the good things are that it's constantly being revised by experts in the field, and it really helps narrow down some simplified diagnoses, and it covers a lot. However, the problem with it are that it's sometimes not that reliable, which means that sometimes one expert might diagnose, where's my mouse? Okay. Some experts might diagnose some things one way and others might diagnose it the other way, which could be a problem. This categorical approach can be challenging too, because let's say you've got major depressive disorder and bipolar disorder. By separating those two things into two categories, we might be isolating some symptoms that then don't get treated by giving a specific disorder. So this is kind of this same thing as comorbidity, right? Lots of disorders can occur together. And when we break them apart into these categories, we might miss some symptoms or some things that we could treat otherwise by boxing things up. Whereas if we kind of let it be like, you have these symptoms and these are classic of these different disorders, but we're going to try to address each of these symptoms and not just, you have depression and this is the one medicine we give to that. If we can use multiple medications or multiple treatments or therapies to address all of these symptoms, that might be better than just categorizing them. And it's also not necessarily sensitive to children. And so obviously children with different mental disorders might be very differently than adults with that. And this DSM-5, we'll talk about this in a second, treats children as just miniature humans, which is not correct, right? Like many children are not even close to tiny adults. Like that's not what that is. So that's a weakness it has there as well. All right, make a sip of this soda. All right, so to actually do a diagnosis, this is pretty, I think, straightforward. You might meet with a psychiatrist, then they would go over the symptoms that you present to them against this DSM, and that can be done through interviews, so they just sit down and talk to you. This is great because it helps to get at things that a patient might not necessarily feel comfortable approaching, but it's also not necessarily the best method. Self-report measures are also great, but we've talked about a little bit before, social desirability, and so people might not always be reporting truthfully what's going on. And then observations are a great measure because you don't see any of the biases that occur between interviews and self-report measures. The problem here is that there are some things that are hard to observe. So, for example, if somebody has self-esteem issues, how can we as an outside observer really get at that by just watching what they're doing and not speaking to them about their feelings, right? So oftentimes multiple measures together will be the best way to really collect what this participant or person's symptoms might be and best be able to match them against this criteria. Okay, they can also use brain imaging techniques. So this can be awesome if, for example, you're having kind of changes in your personality or something that might be due to a tumor. And so using brain imaging techniques can be really great for that. The problem with it is that just because you have a difference in your brain doesn't necessarily mean that that's what's causing a mental disorder, right? So this is not at all causal. It's just more like we can maybe see a correlation between hyperactivity in your amygdala and, for example, heightened anxiety. And it can also be really expensive. So sometimes this is really great depending on the symptoms you're having, but other times it might not be necessary. So there's a couple different types of disorders that you could be diagnosed with or you could encounter. That would be mood disorders. So this is major depressive disorder, which we have frequently shortened to MDD. So if you see that, for example, on your lab journal, this is what we're talking about. And bipolar disorder. Then there's anxiety disorder. So anxiety, just as you'd expect, and PTSD is on there. And then there's psychotic disorder, so schizophrenia. And we're also going to talk some about ASD today. Okay, so as I just said, MDD is major depressive disorder. And these are symptoms, I mean, I think depression is something that is a little bit more widely talked about compared to some other mental disorders. So it comes with all of these symptoms, and it has to be, again, we've talked a lot about clinically significant distress or impairment, but this has to be to a clinical level to count as this. Interestingly, women are diagnosed almost twice as often as men, and this could be for a couple reasons. Perhaps women are just more likely to seek treatment for how they're feeling, right? So we might be getting a sampling bias, and that women are more likely to reach out to get that diagnosis than men. It could also be that women tend to approach things like this in a different way. There's like a rumination type thing where women might think and think and think and think on this sadness, which tends to maybe lead to more diagnoses than men that might choose to try to distract themselves from these symptoms and then wouldn't even know they need to go in, right? This has also got a lot of comorbidity with other types of disorders, which can be very dangerous. And there are some forms that are less severe, right? So you could have persistent depressive disorder, which means you maybe just have this for a long period of time, but maybe with fewer of these symptoms or to a lesser degree. All right, so bipolar disorder is kind of like a mix between depression and then this mania. So the depressive swings would be like very, very lows, and then that mania is just this like euphoric high, right, where they're just bouncing off the walls maybe, or have just incredible flights of ideas. They might be really engaged or more frequently engaging in risky activities during these acts of mania. This is typically kind of, there are a lot of like artists and really famous artists that used to have bipolar disorder, and it's during this mania that many people experience maybe some of their greatest pieces of work or something. And there's a couple of different types. People that have one mania episode are bipolar 1. If you've had maybe mostly just the depressive episodes, you might be bipolar 2. And so the trouble, I think, with bipolar disorder and what a lot of clinicians struggle with is that when people are in their depressive episodes, that is very challenging, and these can last for a long time. This is not necessarily like from day to day. This can be months or years of the depressive episodes, and months to years of this mania. But when people are in these manic episodes, they are feeling really great, and so they typically stop taking their medication when they get to these excessive highs, which means it's really hard to keep people on these treatment plans. All right, so anxiety disorders is, as you'd expect, panic disorder, general anxiety disorder, social anxiety disorder, and this is pretty common. So about 25% of the population might have one of these, although it's hard to really say how many people get diagnosed with that. And so this can have any one of these different symptoms, and there are some associations with personality traits. So those that have higher scores in neuroticism, as you would expect, tend to have higher levels of anxiety. Those that have insecure attachment styles also tend to have more anxiety, things like that. And so this is also post-traumatic stress disorder falls into this. So trauma is any event or a threat of an event that could, be serious injury, sexual violence, and it can also be just witnessing or hearing about other people's trauma. So what's most important here is this trauma does not have to have happened to the person with PTSD in order for it to be traumatic, right? And this can, be really challenging for people to deal with. All right, this is another interesting anxiety disorder, which is this obsession with pulling your hair as like a way to relieve this anxiety. All right, so obsessive compulsive disorder. And so it used to be called an anxiety disorder, but I don't think it is anymore. And so this is really interesting because many people, I'm sure you've heard people say things like, oh, I'm so OCD. And no, they're probably not. People use this disorder nowadays as kind of like a proxy for being like a perfectionist, or for having to have your house be very, very clean. People are like, oh, I'm so OCD. No, they're probably not. Specifically because what OCD really is as a clinical diagnosis is people will get these obsessions, which might be these repetitive, unwanted thoughts. So we could say, for example, your obsession might be you can't stop thinking about that somebody is trying to break into your house and kill you, right? So you're having this intrusive cognitive event over and over again. You're getting this anxiety because you think somebody might be trying to break into your house to kill you, or somebody might do this. And you can't make this obsessive thought go away until you enact your compulsion, right? So you're getting this anxiety from this thought. So in order to keep somebody from breaking into your house and killing you, you might engage in this repetitive behavior. So you might say, I'm going to have to lock my door 73 times over and over and over again in this exactly perfect way in order to keep somebody from coming and killing me in my house. And so this is nothing at all like wanting your house to be very clean, right? This is this idea that you have this level of anxiety from these intrusive cognitive events, and to minimize that, you have to repetitively do these behaviors. So if you've ever seen somebody that has to like close a door like 4, 5, 6, 7 times before they're able to enter a room, they have to flip a light switch a bunch of times, or they have to wash their hands for an excessive amount of time, or all these different things kind of fall under compulsions. And so very different than how we typically refer to this as a disorder, but very, I think, intrusive to somebody's lives if you constantly have to deal with these thoughts and the compulsions to minimize those anxieties. All right. And as I said, this is comorbid with a lot of other things, which we can see here. All right. And as I said, it's no longer considered an anxiety disorder, but it's similar to that kind of like loss of control. So ADHD, this is a pretty common disorder, which is just trouble focusing, hyperactive. You might have issues with self-control. And so this is way more common in boys than girls, and I'm not actually sure why that is, but there's a significant number of children that are diagnosed with this. And so this is frequently comorbid with other like anxiety disorders and other conduct disorders, which if you think about it's sometimes makes perfect sense, right? So if you have ADHD and you have struggle with self-control. Something that frequently causes anxiety is kind of this feeling of lack of control, causes anxiety for some individuals. And so you can imagine that having something like ADHD and feeling frequently out of control would also lead to these higher levels of anxiety. And that also might lead to more angry and defiant behavior, right? Because you can't control this, or you feel out of control, and in order to gain control, you might lash out. So this is something that's frequently kind of overlaps with other disorders. All right, so schizophrenia is very challenging disorder to kind of approach, because it's got two different types of symptoms. So they've got these positive symptoms. Keep in mind, this is not positive as in good. Positive here means this is the addition of something to our thought process, right? So it causes hallucinations, delusions, and bizarre behavior. So it makes these occur. And it also causes these to have an absence. So the negative symptoms are an absence, and this is an addition. So they might have more limited or toneless speech. They might have less affect, so that's less emotion. And so this can be very, very detrimental to how people are able to interact in our society. And it's comorbid a lot with substance use disorders, so that would be like drug use. Ooh. Interestingly, I did research in a lab that was working on schizophrenic interventions when I was in undergrad. And something that we did a lot of research here was with time perceptions. So you can see they have disturbances in perception. And what this means specifically with time perceptions is, if you think about how you're able to judge time, right? If I were to ask you to say, tell me how long 5 seconds is. Most people aren't very good at that, right? Even though it's only 5 seconds, our perception of how long it takes for time to occur is typically a little bit skewed. And for people with schizophrenia, it can be even worse. And so somebody that might have schizophrenia might, in the normal span of a conversation, let's say I were to ask you what your favorite color is. And you would say, oh, my favorite color is blue. In that conversation, there's a normal passage of time, right? So between when I asked the question and when you would give an answer, there is a time gap there. For those of us that have a pretty good perception of time, this is totally normal, and we're able to continue that conversation without any confusion. However, if you had schizophrenia, if I asked you, what's your favorite color, and you said blue, if you were the person saying blue and you had schizophrenia, and I asked you, what's your favorite color, and then you said blue, I guess the other way around. If you had schizophrenia and you said, what's my favorite color, and I said blue, this gap of time between our 2 points of our conversation, for someone with schizophrenia, would be too short. And so the only way for a schizophrenic to maybe be able to make sense of that situation would be for me to have read their mind, right? So they start to have this maybe paranoia of this bizarre behavior because they can't perceive time in normal conversations. And so the lab I was working in was trying to develop interventions to help correct this time perception, to see if we can improve that for them. Perhaps we can improve their ability to, interact with other people. So these videos are really cool. As we saw last time I tried to show you 2 videos in this, doesn't really work. So I'm gonna let you guys go ahead and watch these on your own. Again, I'll upload this so you guys can see all this stuff as well as the video. Oh, okay. So autism spectrum disorder. So this is a developmental disorder. Helps, we've talked about this pretty much the whole semester about ASD. It's pretty common. Symptoms are really widespread, which is why this is a spectrum, right? So we don't really classify people on the spectrum very much anymore. Typically is the idea that people along the whole spectrum might have a different level of skills or symptoms. And so you might say somebody is high functioning, might fall closer to one end of this spectrum than others, but it is just a spectrum. And those people might have restricted interests, more like repetitive behaviors. They might have issues with sensory sensitivity, so they might be very sensitive to touch or sound, and they can often be accompanied with other attention deficits. talking about so many of these. All right, so personality disorders. These are a lot of things. Most importantly, they have to be enduring. So this can't be like a change in personality typically develops when somebody is young and then persists through their whole life, right? And so each of these disorders kind of has a different set of traits that might apply to it. So we're going to look at a couple of them. So you could be in cluster A, which is kind of this odd, eccentric type of personality. So you might be very suspicious or have a hard time with social isolation or detachment. You might have like some weird disturbances. You could be in cluster B, so you're more dramatic, emotional, kind of grandiose, self-important, or have instability with impulses. Or cluster C would be that kind of anxious and fearful type of personalities. I'm not going to walk through all of these. If you're interested in any of them, feel free to just look them up on the internet. Using Google Scholar would be a great option here. All right, so there's lots of different ways to treat these disorders, and I am by no means an expert on this, so I'm going to walk through this pretty quickly. And if you're interested in any of these things in a different way, feel free to let me know. All right, so there's lots of different treatments. There's drugs, which we have heard a lot about, right? These different ways to treat mental disorders using medicine. There's also this cognitive behavioral therapy, and this is a really cool type of therapy, which is trying to use research to develop these new ways of thinking, acting, and feeling for a patient. And so it might be that you have to teach them relaxation techniques if they have lots of anxiety, or change how people think about things, set different expectations. Humanistic therapy is also really cool in that it helps patients maybe just need to become aware of their unhealthy behavior in order to help correct for that in their behavior, or help people recognize how they're really feeling about things, so that when they go to do this behavior, they can say, well, this is how I'm really feeling. All right, so depression, this is the cognitive behavioral therapy, might help somebody with depression in this way. This is an issue though, in that it's really hard to see what, like empirically, so there's not very much research necessarily on what is effective here. And then there is, of course, medications. So many of us have heard of the selective serotonin reuptake inhibitor, which is SSRI. The issue with SSRIs is they take whole weeks in order to become effective. And so patients with depression might start taking an SSRI, start feeling immediately better because of a placebo effect, right? They started taking medicine, that's going to help. But then they have to continue taking them for up to 2 to 3 weeks before there's actually a change in how your brain is processing serotonin. And so if a patient can get to that point, it typically is helpful. But if a patient is falling on and off this medication, they're never going to see any effect. Okay, bipolar disorder. So lithium is actually, I'm sure some of you know, a pretty dangerous medication to be on. And so this is typically not doctor's first choice for prescriptions, but it is something that could treat bipolar disorder. And then there's other things like psychotherapy or more monitoring to help regulate these different episodes that they might have. You'll also see some of this family relationship therapy. This is the idea that a lot of disorders might be, heightened by your environment. And so maybe there's something in your environment that is particularly triggering or making it more stressful. So that's what that's referring to, and you'll see that in a couple other slides. Anxiety disorders, some of these I don't really know about, I'm gonna be honest. So there might be this exposure therapy, or this, I don't know. Here's all these different behavioral therapies you could do for anxiety. Again, there are also some cognitive therapies that you could do, try to think about your anxiety in a different way. PTSD and OCD, again, here we've got that re-exposure, or helping somebody kind of like reprocess some trauma emotionally. OCD, this, I'm not sure if this would actually be helpful, but as I said, there's these obsessions that then lead to compulsions And so I think this idea that if you can expose somebody to this obsession and then show them that that anxiety doesn't need to be calmed using a compulsion, that might help. There's also medication there. For schizophrenia, there's a whole slew of medications you could take that might reduce any number of those symptoms. There's therapy, and then also the social skills training is what my lab was focused on, right, is improving how somebody could perceive conversation through time management. And then there's some other cognitive therapies with attention and face recognition, things like that. Treating ADHD, again, there's that medication thing, there's many behavioral therapies, meditation, family therapy, all things we've talked about. And then if we talk some about ASD, this is by far what I am most aware of. So one thing that is typically very helpful for people with ASD is called applied behavior analysis, or ABA. And what this does is it uses reinforcement techniques, so kind of like this Pavlovian or Skinner's type of behaviorist approach to help improve certain behaviors that an individual with an ASD diagnosis might be struggling with. So there is ABA research at our lab. The department chair is involved in ABA, as well as a handful of grad students. So I have learned more about this than other things, although I am also not an expert. So this typically is most beneficial when a child can start as soon as possible, right? So the earlier treatment can start with somebody with an ASD diagnosis, the more skills and strategies they'll be able to learn and use throughout their lifetime. So ABA would typically look like they would evaluate, the individual, and then they would try to make very specific goals, and these goals could range to a whole different things. So perhaps the person with ASD really struggles with some self-care. So maybe they really struggle to, let's say, take a shower, right? They need to be able to take care of themselves, clean themselves on their own. So that might be the goal. Increase the number of times this individual would be willing to clean. Next, they're going to do some teaching procedures where they might give different reinforcers for different behaviors that start leading towards this goal. Then they train their caregiver, so their parent or their non-related caregiver, to help them use these kind of reinforcing procedures to go towards this goal. Then they're going to look again, all right, so now we've been using these procedures, so how is that evaluating that child's performance? And then they might go back and maybe do another evaluation for a different goal, or if that's no longer working, they might have to reassess the type of reinforcement they're using to kind of improve that behavior towards this goal, whatever that may be. All right, so some important issues. Drug therapy, I don't know why this is here. This is, as I said many times, drugs can be really helpful, although they don't always work, and it's sometimes hard to keep up on them, and there are many side effects. It's also pretty costly. No, is that last slide? No. All right. Things when we think about children, that can be really hard, right? It's hard to make a prescription for a child. It's also much harder to give a diagnosis to a child, as a lot of these disorders change as we age. And so, as I just said, the downside for this is that maybe a child shouldn't be taking medication for these things, as we don't know how that might affect development. Interesting, there are other different, types of therapies that you can do with children that might be better. All right, there are also some other medication style treatments that have kind of come to light recently. So there's this MDMA, or psychedelics like shrooms to treat PTSD has become kind of a thing recently. There's other kind of other still drugs, but not FDA approved drugs for these other types of mental disorders. I've never actually heard of somebody receiving this type of therapy because it's pretty extreme for cases of major depressive disorder. but transcranial magnetic stimulation, this is a really cool kind of alternative because it's able to kind of like use magnetic currents to stimulate different parts of your brain, but it doesn't have so many of the like other side effects as maybe electroconvulsive therapy does. All right, so we didn't talk about a couple things. We didn't talk about intellectual disorders, eating disorders, or substance abuse disorders, and a whole other variety of things. So you will have a participation discussion. If you're interested in any of these things, feel free to look them up. So I'm going to talk really quick about what your participation points will be for today. All right, so if we go here in TCU Online to Psychopathology Lab, we go to this, here's your lab journal. So let me see, do I have it open? No, okay, let's just look at it. You'll see here that for one of these questions, I asked you to pick a disorder from a PowerPoint or choose one we didn't mention. So if you're interested in those ones I just showed, substance abuse, an eating disorder, or an intellectual disorder, feel free to use that when you answer this question if you would like. All right, but to go back to what I was going to talk about, which was participation, you'll find all of that here under diagnosis and treatment activity. And so if we look here, and there's a couple different things. There's this, which is the first document you'll want to open. Topic. In here, we can see that it's a list of symptoms for a patient. And so first, you're going to go through and read this kind of panel. And there's some stuff here at the top that kind of is talking about what you should do. Mostly just read their kind of brief little paragraph about a patient. And then here's the whole assignment if you forget. Then you can go ahead and open these other 3 documents. So these are the actual disorder criteria for these 3 different diagnoses in the DSM. So it will look something like this. And so after you read those symptoms, go through and read these other 3 criteria and see if you can give a diagnosis to this kind of hypothetical patient in this diagnosis and treatment activity document. There's not necessarily a right answer here. I'm not expecting you guys to know what this is. This is really just an idea to get at. This is a challenging thing to do, and it's hard to really figure out what things should be more important in a diagnosis than others, right? So just give it your best shot. Then go ahead and post about it on this discussion board. You don't have to reply to anybody else's post for this. Just go ahead and write what you think the diagnosis should be and just a couple sentences about why. I'm not looking for any crazy explanation of your decision. Just what stood out to you and why you made that diagnosis. So that's how you're going to get your 2 participation points. Your first attendance point will be from watching this video, and then there'll be your lab journal per usual. If you have any questions about the final presentation, please let me know. I don't think I'll be posting any additional videos about the final presentation. So if anything is not clear, please just let me know. All right, guys, I hope you have a good rest of your day. Can't figure out how to turn this off. And bye.